So as we try to move beyond this best of times, worst of times, best of technologies, but some real challenges in using them effectively and getting to a realization, the policy steps that can help get to a population approach to public health to take advantage of all of them, we're going to move to our next panel, and this is an introduction to that discussion paper that we released in conjunction with this conference and that we're going to discuss with our panelists in a few minutes, which means that you all have to bear with me while I go through some of the key points that were included in this paper about how to assess population-level benefits of medical products, whether it's as you heard, the existing ones that we have that could have more of an impact that we are perhaps not using effectively, or to create incentives for ones that could make more of a difference given differences in individual choice and access for containing these conditions. So I wanted to review this framework briefly. I think we'll start this on the next slide. Can you all advance, or is that, do I need to do it? I think I can do it. Okay. So, and we'll make these available in conjunction with the event too. But as we've talked about, a number of products have come to market for all of these respiratory conditions, for that matter, some other infectious disease risks too. These products have benefits for individuals who use them, and depending on the product and the virus and the nature of the disease transmission, also benefits from their use on people around them by reducing complications of additional infections. And further biomedical innovations, as well as more effective use of these existing products, could potentially lead to greater benefits. So this consideration, for example, in this framework leads to questions like, well, if it is possible to develop a product that could avoid mild short-term symptoms or maybe any infection symptoms at all, that's obviously not as important for an individual as saving their life or preventing a hospitalization or avoiding their having to be home for 4 or 5 days with severe symptoms, but it could be important for transmission reduction and population health benefits. That's just an example of what we're talking about here between the consideration of both individual benefits and population benefits for things like net number to treat. And the current evidence assessments for existing products and the associated approval decisions, coverage decisions, and especially outside of a public health emergency, the coverage and payment policies are generally focused on those individual benefits and risks. And so we're looking to whether there could be more effective guidance about additional policy policy development for public and private coverage, for regulatory processes to help put more of an emphasis on these additional sources of population benefits. And as the last panel talked about, try to get to a more unified framework for thinking about public health, healthcare, as population health tools supported by aligned policies together. So on the next slide, goals for today's meeting, we want to identify policy opportunities that could fuel the development and for the treatments that are already, the products that are already developed, the coverage and uptake of medical products that confer a greater population health benefit than we've traditionally been able to achieve. And as you just heard, seems like a good deal of room for improvement. And our panels are going to focus on the policy reforms across different private and public stakeholders that could facilitate progress in these population health benefits, and also thinking about ways to create pathways and incentives for the continued development of next generation products, the continued development of effective strategies to use existing and emerging products to help with greater practical impacts on reducing infectious disease impact. So next slide, this framework for reduction includes, as we describe in the white paper, incorporating the population health benefits of transmission reduction to define a spectrum of product benefits and provide a foundation for a more systematic approach to developing and using biomedical products that have both of these benefits, both individual and population level. And on the next slide, the framework highlights these questions related to the potential value of accounting for these population health benefits and our data and evidence systems and supporting policies. When is a more explicit focus on population benefits of transmission reduction likely to be worthwhile? Think about that in terms of the respiratory season that we're in, respiratory virus season that we're in right now, as well as in more emergent situations. How can we better measure such benefits and validate interventions or ways of using interventions that could increase those benefits? Then do our current regulatory policies provide a clear pathway for products that block or significantly reduce transmission, even if they have relatively modest benefits in additional benefits for individuals? And do current payment policies and coverage policies fully reflect the benefits of transmission reduction, reducing burden on healthcare systems, and reducing public health burden from doing a more effective job of containing outbreaks and the impacts of infectious diseases? And the next slide. This slide talks about a framework for analysis of population health impacts. Remember that products that might be approved because they have demonstrated benefits for diagnosing, preventing, or treating an infectious disease also have benefits beyond the individual using the product, which could come through an impact on preventing sickness and those around them, as Christian was just describing, for many people, especially from more underserved and vulnerable communities who have more exposures and face greater risks like that. Economic benefits from preventing sickness and impacts on workforce, local economic output and productivity, social benefits from maintaining and strengthening health and social infrastructures like keeping students and staff in school and improving quality of life and equitable outcomes in the population. So those are the kinds of benefits that we're discussing today. And this framework includes both the usual individual benefit risk analysis, but also these additional population benefits as we think about the future of healthcare and public health working together. So measures of transmission reduction in this framework could be used to help assess the additional population health benefits of products that we're currently regulating, covering, and paying for based on their, largely on their benefits for individual use, or at least not systematically taking into account these population benefits. And if we had validated markers of reduced transmission, that could be a good basis for both tracking impacts and further guiding policy development. And in turn, that could lead to stronger incentives for developing and using products that are better at reducing transmission or maybe even blocking it in some higher risk community conditions of use. Obviously, there are other steps to help support this work, evidence development, I'll come back to in a minute, modeling, policy simulations, et cetera. So next slide. Building on this framework, so regulatory considerations in particular, so FDA will not approve a product in general unless the evidence shows that its expected benefits for an individual outweigh its expected risks. And FDA does consider in infectious disease products considerations about impact beyond individuals. So there is a precedent in our regulatory pathways for considering not only individual benefit and risk, but also with the these other benefits too. For example, approving prophylactic use of treatments to prevent spread of a viral outbreak in a long-term care facility. But again, looking more systematically beyond the individual and regulatory approvals could provide a clearer pathway for labeling, for post-market studies that could more clearly demonstrate these benefits and have an impact on use and coverage and payment policies. So next slide, moving on towards coverage and reimbursement considerations for a population benefit. As you heard from the last panel, outside of a public health emergency, much of our coverage and payment for medical products that impact infectious disease outcomes for individuals are treated like individual benefits. We did see different policies in the COVID-19 public health emergency with more population approaches to acquiring products and approaches with lower or generally no copays for paying for greater access to these products because not only the individual benefits, but obviously concerns about impacts on local healthcare system, disease spread, and population health outcomes. But moving beyond the public health emergency, we haven't really fundamentally changed those policies. At the same time, there are steps in this direction. CMS is adopting innovative policies to pay for vaccines, diagnostics, therapeutics, and innovative payment policies for healthcare organizations that encourage care coordination and that in some cases, as Christian mentioned last time, could potentially include actual accountability for helping identify and screen people at high risk for infectious diseases like respiratory infections to improve access to and use of these technologies. So potentially further steps there too. And next slide. We've talked about potential applications to respiratory viruses already, so I think I'm going to go through this slide quickly, but hopefully we can come back to further thoughts from our panelists this afternoon on supporting the more effective use of existing products, the effective voluntary use of existing products by maybe changes in procurement, more population-oriented coverage models and payment policies, as well as steps to clarify and advance the development and adoption of next-generation products that could have even more of an impact. So we'll try to bring this back to addressing the respiratory virus threats that we just discussed in the last panel. The next slide, I think this is in the paper. I'm not going to go through these here. Additional examples of regulatory reforms to help realize this kind of population benefit framework. And on the next slide, reimbursement reforms to help realize this population benefit framework as well. And then finally, just to support all of this, as we heard earlier in the first panel, we need better information, we need better evidence. It will take policy reforms focused not only on driving forward these products to get better evidence and their effective use to get better evidence, but also maybe additional steps to build on our current infrastructure and capabilities to learn about population benefits of infectious disease products. Most products get approved, as I talked about earlier, after that showing that they benefit individuals. That's what ends up on the label for those products. For example, for the vaccines that FDA has approved for COVID and these other respiratory infections. But it's also possible to get labeled evidence and evidence that can drive practice guidelines and recommendations that build off of pre-market, but especially real-world epidemiologic research and maybe even real-world practical clinical trials that show not only favorable individual benefit risk, but also impact on spread and outcomes for people around those individuals who use the product. We have some markers for these kinds of benefits in the form of viral load or symptom duration that have been more or less validated in certain infectious diseases like HIV, for example. Can we do that more systematically for a broader range of viruses to help promote and provide a clearer pathway to regulatory labeling and coverage and payment based on population health benefits? All right, that's enough hearing from me and about this discussion paper. I'd now like to open this up to more discussion with our panelists and all of you. I just want to remind people, we'll put it back up on the screen where we're talking, that QR code can be used to submit questions and comments, both from you all who are here in the room and those who are joining online. So let me invite Mark and Chip up while I introduce all three of our panelists. Joining us remotely from Europe, which means I think we're covering 10 time zones today, is Blythe Adamson, who's an infectious disease epidemiologist and economist, and the founder of Infectious Economics. I like that term. Mark Lipsitch, who's professor of epidemiology at the Harvard T.H. Chan School of Public Health and director of the Center for Communicable Disease Dynamics and the Interdisciplinary Program on Infectious Disease Epidemiology at Harvard, and Chip Petricoin, who's co-director of the Center for Applied Proteomics and Molecular Medicine at George Mason University. So we're going to start with some opening comments for this panel from each of our three panelists. Then we'll go into discussion. And again, please send us your comments and questions to add to what we've talked about so far. So Blythe, thanks for joining us. I know it's getting late there. We really appreciate your being with us virtually. Oh, and we are not hearing you quite yet. Hang on one second.
Okay, I'll try
there we
again.
Go. Okay, thumbs up.
Oh, can you hear me now?
Thank you.
Great. Well, thank you all for inviting me to be there with you virtually. This new framework is incredibly important, and it brings up points that we haven't seen in other regulatory or payer frameworks before. And I think just to reset for me at a high level, what I think that this brings us closer to being able to achieve is just what Mark said, which was incentivizing the invention and development of diagnostics, treatments, and vaccines that create this spillover benefit of population health. So really motivating manufacturers to understand that we as a society value this, and we want to be able to reward inventions of this type and be able to bring them to market and create access that allows us as a society to capture those benefits. But I think that we've discussed so far many of the challenges that hold us back from that. And I'm hoping that I can describe in my few minutes a few of the solutions that I wholeheartedly agree with that the framework is bringing up. So the two high-level ones that I want to draw attention to that are described in this framework are first the opportunity of quantifying the benefit to society that the attributes of these products bring. And I see that as coming through bringing together two different disciplines that within the United States, we traditionally don't have many academics or researchers with this combined skill set. And that is in health economics, which is being able to weigh trade-offs and understand the monetary value of new drugs, diagnostics, vaccines, with this field of infectious disease, dynamic transmission modeling, and being able to understand how the attributes of these different products creates greater value to the sum of our society than it does for adding up the benefits to the individuals who use these products. And so really the intersection of bringing together these disciplines of health economics, which combines together the three outcomes that are included in this framework of understanding the clinical benefits, the economic benefits, the social benefits, with decades of methodology of how to incorporate quality of life, workplace productivity, all of these attributes that we know are important and can have consequences to our society. With the nuances of infectious disease dynamic transmissions and how those work within populations. So the second part that I'll emphasize that I think is really incredibly progressive in this framework is its call to action for the development of real-world evidence. And we've heard mentioned several times of the importance of having great data. But when these products come to market, if they have not yet been evaluated or there's still great uncertainty about how the product may change the magnitude of someone's infectiousness at a moment in time, or the duration in time that they stay infectious, or someone's susceptibility to becoming infected if they're exposed. This is where real-world data, and I'd advocate within cohorts of or workplaces, the populations of people where we can conduct real-world studies to be able to understand these attributes. This is where I think that we're going to see a lot of opportunity in the US to gain confidence. And I think both of those together, it's really a learning healthcare system, developing great models for simulating policies, being able to generate real-world evidence about how well these policies are working, how well these drugs, vaccines, diagnostics are performing in the real world. That's what's going to allow us to be able to make those updates, as Mark said, to expanding label indications or being able to optimize the cost effectiveness in how we're delivering these products. So I'm really excited to hear the rest of these conversations, but I think that where I'm hoping I can add perspective today, though we've got academics and government, nonprofit, industry, public health, providers, patients. I'd really advocate that an important stakeholder at the table are businesses in America. They're the ones that are able to capture a lot of these benefits of reducing transmissions and keeping our workforces healthy and at work and productive. Whereas within the United States, in a fragmented payer system, we are asking health insurance companies to subsidize and invest in benefits that are not going to necessarily be captured by the individuals within their population of care. So I think that this framework does bring us to a point of trying to understand how much do we value the attributes of reducing transmissions, and who should be willing to pay for those? How much are we willing to pay for those attributes? And how can we quantitatively be able to describe that and incentivize manufacturers to be able to continue to invent new products that bring us societal value in this way? So thanks, Mark. I'll pass it on to my next panelist.
Thanks, Blythe. Some great comments and great questions to end on that I will be bringing right back to you all. So Mark, I think you're up next.
Sure. Thank you for the opportunity to be here and for a really thoughtful framework. I think it really is a useful way to think about a lot of these problems. I wanted to start by just sort of putting in a bit of history and noting that there's pretty good quantitative evidence of population benefits of vaccines for a range of different vaccines. A short list would include diphtheria, pertussis, measles, mumps, rubella, flu, and COVID-19. And I want to mention that one again because it was pointed out in the last panel that this is far from a perfect preventer of infection, especially with the more recent variants. But two important points there. One is that we need is that there is, even with Omicron and even with slightly waned vaccines, there has been evidence, for example, from the California prison system, of reductions in transmission, modest ones, but measurable, from being vaccinated against COVID-19. So I think and the other point is that we don't have to have perfect vaccines to make a population-level impact. Smallpox was not eradicated because every single case was prevented. It was eradicated because each case was made uninfectious enough so that they infected less than one additional case. That's sort of the central concept of infectious disease epidemiology and really important to this. Reducing is good and will have multiplier effects. For treatments, we also have very good evidence of treatment as the prevention, as a or the prevention strategy for tuberculosis, gonorrhea, syphilis, chlamydia, HIV, and strep throat, among other infections. So there is a long tradition to draw on there. I think in diagnostics, the case is probably the least clear at this stage for a number of reasons. First is that a diagnostic does not by itself prevent transmission. It alerts people to the opportunity to change their behavior to prevent transmission. So it requires something more than the diagnostic itself. Secondly, if you use a diagnostic and find out you're negative, you need to use it again tomorrow and again tomorrow and again over time, so it requires long-term use. And thirdly, diagnostics until recently were largely in the hands of the healthcare system rather than of people, and so it was not as readily thought of as a prevention measure, but I think that's beginning to change. As we think about all of these, and I'll finish in a minute with some ways forward as I see it, but I think it's worth defining this really clearly as a public goods problem, and Blythe made important reference to this in her comments. The challenge, one of the challenges is that the payers, which are fragmented in our system, of multiple payers, are not capturing most of the benefits of what they get. There are some exceptions, and I think that points to a way forward. One is workplaces, which she mentioned. We have workplace flu clinics and COVID clinics. I think a lot of that is probably thought of as preventing individual infections, but it is also reducing transmission, and quantifying that would be important. The other is households. So because of employer-provided health insurance, most households contain people who are covered by the same insurance. So I think household transmission is an important subvariant of community transmission, or an important part of community transmission, where the benefits actually are captured by the payer. Two studies in Science a couple of years ago showed from different HMOs in Israel that they were able to show very large benefits to preventing COVID-19 in unvaccinated children by vaccinating the parents of those children. And that is savings to them. So what do I think we need to make these things, move these things forward? I think for diagnostics, a crucial piece is to have licensing criteria that understand the public health uses and the prevention uses of diagnostics separate from their clinical use in figuring out if someone has the infection or not. In COVID-19, there was a lot of difficulty in getting particularly the lateral flow assays licensed because they were so-called less sensitive, but that means that they were not picking up often PCR of very, very little bits of virus that were probably not infectious. Blythe has recently shown that they also fail sometimes to pick up infectious cases. So they are not perfect for detecting infectiousness, but they have a very important role, and there was not a path to licensure that really emphasized that. And Michael Mina and Dan Larimore in the New England Journal made a really compelling case on that. I think figuring out ways to study these in contexts of congregate settings such as schools, nursing homes, and workplaces is another important way forward so that, again, the people that capture the benefits, the firms that capture the benefits will be incentivized if they see the benefits of using a diagnostic program. And those studies could be done. The equity issue is important. If we focus on getting diagnostics to employed people or other people of higher socioeconomic status, we need to make sure we're not leaving behind those who are not. And then I think the issue of payment structures. How do we demonstrate the cost effectiveness of having readily available diagnostics so that normal activities can go on? In therapeutics, I think we need better designs for studies that try to show the transmission benefits of therapeutics. We're working right now on a reanalysis of the treatment as prevention study in Botswana, which showed a modest impact of treatment of HIV in preventing transmission of HIV. But probably a lot of that impact was not measured in the study, as our work right now is showing, because people were receiving infection from people who are not in the study. And so the study underestimated the total benefit. So we need to improve the methods for studies. Similarly with vaccines, there are lots of studies designs that have been used to show changes in transmission, reductions in transmission from vaccines, ranging from dynamic studies to household studies to workplace studies and community studies. Those are like, I happen to know about those because I collect those because I give a lecture about it, but there's not a central paper that says these are the ways to measure transmission benefits. That paper should be written and it needs to be better understood. And we need to be able to do it repeatedly because we've seen with vaccines for COVID that what a vaccine does today is not what it does 6 months from now because of new variants and waning. So we need to be able to do these studies repeatedly. And I think finally improvements in data, which we heard about in the last panel, are going to be complementary to this. Israel was the leading country for vaccine studies, or one of the leading countries, Qatar another one. What they have in common, and the UK another, what they have in common was excellent data systems, relatively few payers who had an interest in maintaining those data systems, longitudinal data on people and households, and the payer providers in the US are fewer, but are also an important resource for that. Thank you.
Great, thanks much. Mark covered a lot of ground. Chip?
Yeah, I mean, and to maybe cast a little bit of a somewhat sanguine view on this, I think that we're in a much better position, obviously, with therapeutics and vaccination and diagnostics than we were at the beginning of the pandemic. But one of the things we're really in a much better position on is our clairvoyance. What I mean by that is, and I think the first panelists were equally optimistic, our ability to use wastewater detection to be able to really assess at the population level a proxy, and even down to the individual level. It's amazing how in a number of the papers we've been able to extrapolate the viral load in a wastewater testing to individual level based infection rates is fantastic. And my lab's participating in things like the RADx program, and the RADx program is a way to have allowed the utility water systems around the country to start monitoring, for COVID and RSV and monkeypox, detection in a multiplexed way is just beginning. But I think it provides us a really great way of providing a sandbox to use for real-world evidence collection. The FDA has been very, I think, creative in the oncology field of allowing real-world evidence to increase label expansion to new indications. And using the data collected from wastewater detection could be a really great way of allowing a molecular test output, quantitative, to be able to determine vaccination of efficacy, surge diagnostics, education awareness, all the things that you'd want to overlay in a system. We have a really nice molecular surrogate. Imperfect, but it's distributed, it's out there, and the technologies have been, I think, advanced to a point where the precision and accuracy of the underpinning tests are believable, pass muster, if you will. And I think if we reimagine this as, in the oncology field, how we're using a liquid biopsy-based testing to determine an individual's disease progression, if we think about, wastewater detection as a population-based liquid biopsy, if you will, that allows us to understand at a population level how we're doing. And this in the oncology field has changed the way the patient care is managed, treated, individualized, is a great, in some ways, I think, proxy for what we could potentially do in a population-based health arena. I think the FDA would also be, like, I think, very much interested to see how the real-world data that you're collecting is able to serve as a proxy for individual health. And perhaps like in a post-market surveillance or pre-market commitments, you could perhaps have the FDA think about, as they did in oncology, bringing in breakthrough designation, fast-track approvals under PDUFA, being able to provide industry perhaps with faster review tracks if they had population health-based attributes, either in their label or aspirationally, that they want to aspire to perhaps after a post-market analysis is occurring. I think there's ways for, as you said, for the industry to gain benefit from increased opportunity for patent life. If we start thinking about population-based health opportunities for vaccination and diagnostics and preventatives, like we do rare diseases, and we incentivize pharmaceutical innovation in the rare disease field, we could think about some of those same types of innovative aspects, increasing patent life, increasing opportunity for monopoly at the beginning to try to incentivize people to to go forward. And then from the payer side, we're absolutely going to have payers think about the population-based benefit, maybe with molecular surrogates through wastewater testing or other, that are valid molecularly, quantitative, that provide population-based benefit, that the individual risk benefit and the population global benefit start to, instead of it being much more thinking about, do I pay for this test, the CPT codes are coming in at the individual level, and thinking about this at the population level, where we have a different code structure perhaps that provides incentive and also the economic benefit, incentive to, you don't have to necessarily test 20,000 people at $5 a test, but if you had one test a day in a wastewater facility that was essentially screening 1 million people, that has a different price point, perhaps, and it's not a $5 test. And so we could be thinking about this in terms of how do we incentivize these companies to be able to make a profit outside of just the government, giving them, contracts at the taxpayer's dime. So I think that a lot of the framework that we're talking about here can help to incentivize, but I'm really maybe overly sanguine, but I'm very sanguine about the way that wastewater testing can help us with a tool that is really so much better than we had even a few years ago. The infrastructure is allowing us to gain insights and monitoring and surveilling, much better than we ever could before.
Great. I want to thank all three of you for laying out some very clear ideas about what this kind of population health framework means, going beyond the focus on individual benefit and risk. But collectively, I think all three of you illustrated how you can take that individual level concept and extend it out to the population level. Mark, in talking about diagnostics, and you're saying, well, just because a diagnostic shows that it's sensitive and specific, it doesn't mean anything. Just reminded of all of the health economic evaluations I've seen of diagnostic technologies for individuals. We're back to Blythe's point. Well, okay, but what did people actually do differently to treat this individual based on the result of the diagnostic? You all also talked about an evidence framework, because obviously you can't make good policy decisions without good evidence. Also harder to bring along the public and all these stakeholders, employers, government, communities that you would hope to act differently based on this approach. So I just want to follow up on a few of these issues. And just in terms of the basic concept here, on the first panel, Brandon talked about we need to get back to net number to treat. And people have thought about that from an individual standpoint. Is there an NNT analog for population benefits of some of these technologies, or what's the best way to summarize the implications of this framework for going beyond individuals? Blythe, do you have any thoughts on that? You're at this economics.
I was delighted to hear the number needed to treat in this earlier session, because it's a fundamental part of understanding the cost effectiveness of a vaccine, a therapeutic, or a diagnostic test. It's one of the outputs of what can come from a good policy simulation model. So we need to be able to understand both the cost effectiveness and the budget impact. So, just, I guess, stepping back at a high level, how do I think about the return on investment, the ROI from spending on these biomedical interventions to reduce transmission? Well, just to bring it to life for one specific example, I've worked with professional sports leagues, with Broadway theaters, with factories in the US, retail across the country. And the way that groups often think about this is, how much money should I be willing to spend on biomedical products just to reduce the likelihood of transmission? And what you find is that you can back calculate how much someone would be willing to pay based on the cost consequences of that. So if at a factory that has 1,000 factory workers, and you can find out that if more than 10% of them are out with a respiratory illness and a sick day on one day, that factory closes. And the consequences of that closure are, $200,000 lost per day. And the likelihood that you can calculate out through models and transmission probabilities, really how much someone might be willing to pay. But the number needed to treat is completely dynamic and dependent on things like what the prevalence in the community is at the time. And this is why it's really important, I think, that often the value of these products is dynamic and changing over time, can be changing seasonally. It could change with different geographies or risk groups. So all of that to say, the number needed to treat is an incredibly important part of the calculation of how much we should be willing to pay, what's the quantitative value of how effective these products are in the dimension of transmission reduction.
Great, thanks, and I appreciate the trying to work in some of the comments and questions that have come in, so please keep those coming too. But thanks, Blythe and Mark Ship, just turning to you, and just reminded me that you all talked about benefits beyond the individual to whom. So we've talked about overall population, we've talked about workplaces, congregate settings, schools, prisons, et cetera, and households. So those are all important considerations. I'm just wondering if you all have some additional clarifying thoughts on what, as Blythe said, there are a lot of situations out there. How do we keep this as focused as possible to get to things like clear evidence relevant to claims and policy implementation?
Yeah, I think that the sort of inputs to the calculations that Blythe is talking about are ones that we're not very good at measuring. There have been, as I say, there's like a scattering of different study designs that have different strengths and weaknesses that are kind of done by one person here and one person there. It's not a fully developed science, so I think working to really nail down how much, by what proportion do we reduce the chance that someone is a link in a transmission chain. That's really, from the infectious disease epidemiology perspective, all the effects on my being a link in a transmission chain of my getting vaccinated are what we need to measure, and it's multi-components. It's, if I get vaccinated, does it protect me from infection when I'm exposed? If it doesn't, does it reduce the amount of virus that I shed, either at any moment in time or for how long I shed it? Those are the three components which the discussion paper nicely points out. And what we really need is sort of the composite of all of those for each vaccine. And for something that's basically provides sterilizing immunity, like a measles vaccine, it's almost all in the prevention. It's not that much about breakthrough. For something like COVID, it's a bit of each, and it's probably changing over time and with variants. So I think improving the techniques to measure those pieces, and then also trying from the other end to look at these group level outcomes, like household attack rate, where we don't know all the individual pathways by which the household gets protected, but we know that there's a very large reduction in the probability of a child getting infected if the parents are both vaccinated in a household in Israel. So going from both ends of the deeply mechanistic and the phenomenological.
Yeah. Chip?
Yeah, I'm just thinking about, the whole discussion on the NNT, the number needed to treat, and as Blythe said, the key to that is understanding prevalence, and that's why I think things like wastewater detection understand as at a population, even regional, and even at a building level, so efficient, right? And it's non-invasive. You don't have to worry about, getting consent from patients or subjects. You don't have to worry about, HIPAA. You don't have to worry about some of the roadblocks that may prevent. You don't have to worry about even an economic disparity. You can measure it in wastewater at different points, and all of them, that infrastructure is all known. We know all the points of where to measure down to, prison populations, healthcare systems that are treating at the local community, healthcare clinics. We know where to test in the sewage system. And it's amazing what that can be real-time data. And that's one of the things that Radix is trying to do, is kind of real-time data. That can be uploaded quickly for kind of like real-time surveillance analysis. And that gives us the ability to understand population-based prevalence, which may help with looking at then what is the number needed to treat, and then providing this as a data output for overlaying all these important considerations. And if you're going to be looking at, ICER-based, rigorous analysis of the impact, for payers or for all the people that are the stakeholders, a main consideration is what is the endpoint you're using, the clinical endpoint, usually, outcomes, progression-free survival, some of the things that we would use as like the cut to the chase, is this having a clinical impact? Quality adjusted things. We could use some of these molecular surrogates now, maybe more effectively, to be able to maybe more effectively model the impact of certain interventions.
Let's talk a little bit more about building an evidence infrastructure here, because I'm hearing two directions. I know you all have also, by the way, raised a lot of policy implications which depend on this evidence, so we're going to get to that in the next panel too, so thanks for teeing up that as well. But the way that I think, Mark, maybe evidence has traditionally been approached in this space is, can you get longitudinal data on a population of individuals who are having some kind of measurable interaction and track impact? And it does seem like while the U.S. has been criticized, appropriately so, for fragmented data systems with multiple employers and multiple coverage systems and people switching coverage, we are seeing some progress there. Mandy Cohen started out by talking about efforts to bring together data through whole communities on spread of infectious diseases and DUAs and further progress in electronic standards and data protections to learn from that, both for surveillance and for helping to guide further interventions, and those seem like the same kinds of systems that could help with some of these questions. From a healthcare standpoint, it's true that people do switch coverage, but once you're in Medicare, and Medicare is taking some important steps to try to improve population health outcomes. In fact, a lot of the data reporting we do have now related to COVID is through CMS authorities, not CDC authorities, because of this potential benefit for the Medicare population. Medicaid and commercial insurance are increasingly covering families, low-income families in the former, and families in workplaces in the latter. So that seems like one further set of directions. And then on the really interesting idea about sort of population health outcome evidence based on wastewater surveillance or some kind of, that is, I guess, the cheapest, most reliable mechanism we have for sampling in a population, geographic area that can get pretty localized now.
Yes.
So those seem like the foundations for going forward here. And I don't want to have too much time, but would appreciate thoughts from all of you on how do we get this infrastructure for evidence development more routinely in place. This seems like it's like a public good for public good evidence and public good impact. So like triple public good. So this can be hard to fund sometimes, the economic models. Blythe, do you want to start?
Oh, well, we haven't really defined what our gold standard is for being able to say that we have proof that something reduces transmissions, is likely to, as Mark was saying, by what proportion does it reduce the likelihood that someone is going to, be a link in a transmission chain. And, we've got, I think in the United States, a smattering of random studies that we've seen that are just incredible treasures. They're often in smaller cohorts of people. We've heard prisons mentioned sometimes. There are some nursing home studies, workplace studies, where we have this multimodal data that includes, for a population of people, viral load testing longitudinally over time. We've got the genomic sequences that allow us to be able to figure out who passed it to who within this population. And we have, all not just contact tracing, but the exact mixing within the population, all documented. But even so, when we see real world studies like this that have collected every dimension, have additionally collected air quality in those spaces, those things can be sent to peer reviews and to be totally shot down for not still being perfect. So I think that we still are struggling, and as a scientific community, as in public health researchers, of even being able to say, if wastewater is, good enough here, what even are we saying is the perfect way to generate proof evidence so that we can understand what other levels of evidence may be sufficient for being able to give us confidence in decision making for regulatory policy and coverage. So if we can appreciate the treasures of studies that have collected all the different types of data that we would need to tell the story and cobble together why we think we have evidence of the transmission, how can we incentivize building more infrastructure for that type of real world data collection so that we can conduct more of those studies and apply them with methods in a focused way to be able to test the effectiveness of medicines and policies.
Mark?
Yeah, I agree with that. I think one distinction I would draw is that we don't need to know how well a vaccine or drug is preventing transmission everywhere. This is not a fundamentally it's not the same as following the burden of disease. So we can free ride on the places that do have good infrastructure, which could be a payer provider in the United States, it could be other countries. I mean, we don't need to do a study in every community to find out that a vaccine prevents transmission or that treatment reduces transmission. So I think we shouldn't try to build something we don't need, which is a perfect system to do it everywhere. On the other hand, we want to be able to monitor that it's still doing what we think, so we need something. And I think So as an example of using the best resourced places to study them, the Center for Forecasting and Outbreak Analytics, which Ann Zink referred to and I'm involved with at CDC, has been working with payer providers, for example, to design studies to estimate some of these kinds of effects. Not exactly transmission effects, but other relevant parameters for understanding transmission dynamics. And you don't have to be able to do it everywhere. You have to be able to do it well a few places. I want to be a little bit less enthusiastic about wastewater. I think it's a big advance, and it will be the best thing we have in many places. Ann mentioned that much of Alaska has no sewage system because it's on septic tanks. A lot of the rest of the United States has the same issue. And importantly, you don't typically get demographics out of wastewater yet. And we also don't get a very good quantitative signal in terms of being able to really track transmission. So I think it's a very positive way forward. It is not transmission. It's a noisy, semi-quantitative surrogate at present. So let's try to make it better, but I don't think we're there yet.
And Chip, if you want to comment on that, I think you don't figure out what you need and don't need. Before figure that out, you can figure out like what are the right questions to ask and answer. And it does seem like wastewater may be more helpful initially in advancing this work in some settings rather than others. And I don't know, prisons, other kind of institutional settings. What are your thoughts on how to move forward wastewater testing as a practical next step as part of this overall evidence infrastructure?
Yeah, I mean, I think that the community understands the limitations pretty well. I think we're transitioning from we don't know what we don't know into we know what we don't know, which is helpful. We're not completely there yet. I think there's still we don't knows are still there. But I think, there's a lot of technological development and even things like smart toilets and being able to do, septic-based analysis, even group-based septic systems. They're coming. I think that one of the things that hasn't been mentioned, I don't think, is I think there's a very good opportunity to work with the VA system and some of the VA hospitals that are under obviously with Tricon and with other governmental payers and confederated medical records and lifelong medical record keeping, that being able to work with the VA doing wastewater testing, we're starting to do with some of the different VA hospital systems. Those are interesting areas because you could potentially tie into, maybe more robust, homogenized, not a lot of Swiss cheese in the data later. So I think that some of these systems like the VA may be really nice partnering opportunities for payers, for CDC, for all the stakeholders at the federal level. We're going to have to think about this, like we're at war with these pathogens, right? And COVID just took 1 million of our citizens. So to think about how we would combat this at a federal and then regional and local level. And some of this is going to have to be paid for at the federal level, just like we pay at the federal level to surveil for our protection. And so, we don't just kick everything down to the household every single time and just say, figure out how you're going to get this paid through your insurance. And if you're underinsured or uninsured, tough luck. Yeah. So I'm hopeful that the partnership with things like the VA could provide new opportunities to understand better how transmission reduction could really benefit us in the long run.
Mark, can I add one more point on?
Yeah, please do.
I know that we're almost out of time. Is that allowed?
Yeah, it's got to be a quick point, but please do.
Okay,
Definitely give you
really
the last
quick.
word.
I think we've not talked enough about drugs and treatments, and I just want to leave everyone with a thought experiment of if there was a hypothetical drug that once you find out you're positive for a respiratory illness, you could take this pill, one pill, and 24 hours later, you're not infectious to anyone. How much would you be willing to pay for that? Who should be willing to pay for that? how would the FDA approve that? How would we figure out the value of that product? Because for society, it would be extremely valuable. But in my example, like it would not change my health outcomes at all. That's what I hope that together, this type of framework can help us be able to advance to understand how we would incentivize and value products with that type of drugs with that type of transmission reduction.
Well, thanks for ending on that very clear example. I think what came out of this discussion, I know, Chip, you started sanguine, hopefully you ended up there too, but what came out of this discussion, I think, is a lot of ideas on how to make this kind of framework clearer. What is it that we should be looking for? These kinds of cases that Blythe was describing are important, but also how to develop the evidence, both building off individual and family and other longitudinal data, and off what we can sample in communities. It does seem like this is going to match up with some of the overall issues around surveillance, good information that Mandy Cohen started out with at the beginning, and with our efforts that we talked about in the first panel to try to get healthcare and public health working better together on advancing population health. Thank you all for a great panel discussion on these kind of important, if fresh and not yet fully worked out topics. Next, we're going to turn our next panel to a discussion of the policy implications, and we're going to take a little bit less than 10-minute break before we reconvene with that panel, which Christina Silcox, who's our research director for digital health, will be moderating. Thank you all very much for being with us, and special thanks to all of our panelists.